morning, myself Dr. Alpesh Sarvaiya, Associate Professor in Cardiovascular and Thoracic Anesthesia, UNMICRC. Now today we are going to learn about the anesthetic implications for the robotic thymectomy. So we will introduce the first about the thymus gland. What is the thymus gland? Thymus gland develops embryologically from the third pharyngeal pouch on each side. Thymus is a superior mediastinal retrostellar organ and is bilobed, and there are two subcomponents, cortex and medulla, and it is made up of the some tissue like the epithelial, dendritic, mesenchymal and endothelial cells. Thymus is one organ that has already reached its maturity in utero and involutes as the people ages. Now, removal of thymus gland is a commonest anterior mediastinal surgical treatment and is proven procedure for both malignant as well as benign thymus tumors. And thymectomy is now a well recognized surgical method in myasthenia gravis patient, and at the same time thymectomy is a primary procedure for the thymic tumors, especially in early stages. Myasthenia gravis is a rare autoimmune disease that is characterized by fluctuating muscle weakness due to the autoantibodies against the nicotinic acetylcholine receptors or other related functional molecules at the neuromuscular junction. Thymoma frequently is associated with several types of disease, of which myasthenia gravis is the most common. However, performing the anesthesia in patient undergoing the thymectomy can be challenging for the anesthesiologist due to the potential for the respiratory muscle weakness. Thymectomy was previously done through the lateral thoracotomy, then medial sternotomy, and later through the video assisted thoracoscopic surgery, that is called VATS. But now a more advanced approach using the robotic assisted thoracoscopic surgery, which is called as RATS, is now used. RATS is in particular offers some unique advantages like capacity for 10 times magnifications, 3-dimensional visions and high precise dissections of thymus gland. This minimally invasive surgical technique presents a challenge for anesthesiologists due to the impact of myasthenia gravis on perioperative anesthetic management. Now we are going to go through the anesthetic consideration in this robotic assisted thymectomy surgery. Pre-operative period, anesthetists will make a personal assessment of the patient, but it is also necessary to seek the opinion of the medical as well as surgical team. Neurological assessment prior to the surgery performed to evaluate the presence of any active symptoms of myasthenia gravis. Drug history is the more important. Most of the patients of the myasthenia gravis undergoing the steroid treatment. Steroid therapy can cause the adrenal suppression and is widely held that the patients who have recently received the course of steroids may not be able to produce adequate surge of endogenous glucocorticoids to meet the stress imposed by the surgery. It is usual, therefore, to administer the parenteral hydrocortisone to such patients in a perioperative period. The common practice is to consider the 25 mg of hydrocortisone at the time of induction as well as the 100 mg of hydrocortisone over the next 24 hours in addition to the usual dose if the patient has received the corticosteroid for over the 1 month during the preceding 6 to 12 months. There are sometimes will be a large thymic mass may cause the tracheobronchial compression, also superior vena cava obstruction and sometimes even the cardiac tamponade. Now we will get through the one by one, like the complication of large thymic mass. The large thymic mass may cause the tracheobronchial compression. It may be asymptomatic, but there is a frequently a telltale wheeze. Anesthesia may precipitate or exacerbate the airway obstruction in this patient, and obstruction is not always relieved by the tracheal intubation. An inhalational induction is recommended for such patient, and alternatively awake intubation under local anesthesia with fiber optic bronchoscopy is a very safe technique. Ketamine induction followed by the blind nasal intubation under tropical anesthesia has also been advocated. It is said that long thin tubes with side ports can be manipulated to allow ventilation distal to the site of tracheobronchial compression. In extreme cases, extracorporeal circulation has to be considered for prior to the anesthesia. Another problem of a large thymic mass is superior vena cava obstruction. Superior vena cava obstruction causes the edema of the head, neck and arms. Respiratory distress is common and severe hypotension can occur under anesthesia. Drugs and fluids should be given from the veins of lower limbs, better to avoid from the upper limbs and the central venous catheter. Bleeding in these particular cases of superior vena cava obstruction is considerably high during the surgery, and pre-operative radiotherapy or chemotherapy will markedly reduce the anesthetic risk. Other problems are rheumatoid arthritis, Hashimoto thyroiditis and thyrotoxicosis can all be associated with myasthenia gravis, and this condition pose their own problems to the anesthetist. The myasthenic patient is more at risk from the complication of the intercurrent respiratory disease or from the respiratory embarrassment due to the obesity and depression drugs. It is important to assess the likelihood of the myasthenic patients requiring the postoperative ventilatory supports. 4 risk factors which are weighted with the point system, such that a total score of greater than 10 should indicate the need of postoperative ventilatory supports. These are the 4 factors are as follows. The myasthenia diagnosed for more than 5 years previously is to be given 12 points. Chronic respiratory disease given 10 points. Maintenance dose of pyridostigmine greater than the 750 mg per day 8 points, and vital capacity less than 2.9 liter given 4 points. If these 4 factors consider the score greater than 10 should indicate the need for postoperative ventilatory supports. The condition of the patient should be optimal prior to the surgery, particularly with regard to the control of myasthenia and freedom from the respiratory tract infection. Routine biochemical and hematological investigations should yield the normal result. Hypokalemia is to be particularly avoided, as this will exacerbate the myoneural weakness. Nutritional status of the patient should be good. Lung function tests do not contribute very useful to assessment, as they do not measure the respiratory muscle fatigability. So the lung function test is not that much important in these cases. Physiotherapy, bronchodilators and antibiotics have traditionally been used to improve the perioperative respiratory function. Plasma exchange is now being used for this purpose with promising results. Now, the pre-medication. In pre-medication, anticholinergic drugs are often included in pre-medication because they carry some additional advantages. And these are the reduction of the volume of the salivary as well as the bronchial secretions, but at the cost of the viscosity increases. Some protection against the vagal reflex is also be there with cholinergic pre-medication, and sometimes limited antiemetic effect is also there. The analgesic properties of opiates, pre-medication drugs may reduce the requirement of the anesthetic agent during the surgery and may carry through into the early post-operative period. Unfortunately, opiates depress the respiratory drive, which is an important consideration in myasthenia gravis patient. Likewise, the benzodiazepines, which are useful sedatives, are unsuitable for the myasthenic patients. Now, this is the components of the robotic system. The first one is the surgeon's operative console. Second one is subject size card with the interactive arms of robot, and third one is the visual systems. Now, in perioperative period, an intravenous line should be set up before the induction of anesthesia. All invasive cardiovascular monitoring usually that requires. If necessary, this is performed before the induction of the anesthesia. And ECG and or invasive blood pressure monitoring normally provides the adequate monitoring of the cardiovascular system. Neuromuscular blocking drugs are best avoided altogether when dealing with the myasthenia patients, because the adequate muscles relaxation can be achieved without them and their effects are wholly unpredictable. There may be a resistance to the suxamethonium, but there is a risk of developing the prolonged phase 2 blow. Peripheral nerve stimulator, also called the train-of-phone monitor, is used to assess the neuromuscular transmission when neuromuscular blocking drugs are used. Myasthenia gravis patients have unpredictable response to the muscle relaxations and increased susceptibility to the post-operative respiratory failure, which could lead to prolonged dependence on mechanical ventilation. These patients are more vulnerable to developing the pneumonia because of the weakness of cough reflex and immunocompromising status due to steroid therapy. Long-acting non-depolarizing agents like the atracurium has been reportedly used without complication in myasthenia patients for the non-thymic surgery. Use of volatile agents with the myasthenic patients greatly reduce the muscle tone and facilitates the smooth anesthesia. Placement of left-sided double lumen tube confirmed by the fiber optic bronchoscopy. After patient positioning, one lung ventilation to be initiated prior to the insertion of trocars. Now this is the position for the robotic assisted surgery. Positioning of the patient should be done as shown in this patient before docking of the robotic arms. It is important to exercise the caution as there is a risk of displacement of the endotracheal tube. Even after the tube has been correctly positioned, there should be monitored for any changes. This is particularly important when the robotic arms have been docked, as access becomes the more difficult. This also applies to the invasive lines, which can easily become kinked. Therefore, the ongoing monitoring is essential to ensure the tubes and lines remains properly positioned and functional. So, the endotracheal tube patency and patency of central lines to be checked after the position for the docking and after the docking. Now, intercostal block using the 0.3 ml per kg body weight of bupivacaine 0.25% to be given in 3 regions, like in the left third intercostal space in mid-axillary line, in the left fifth intercostal space at the anterior or mid-axillary line, and also in the left fifth intercostal space at the parasternal line. Additionally, the local anesthesia in subcutaneous tissue as field block is to be given using the 2 to 3 ml of bupivacaine 0.25% at each side of the robotic arms to be infiltrated. Carbon dioxide gas is used for the insufflation of the pleural space at the flow rate of the 5 to 8 liter per minute. Raises the intrapleural pressure and expands the surgical field to improve the view by pushing the diaphragm down towards the abdomen. This could lead to hemodynamic instability and due to compression of the mediastinal vessels, resulting in arrhythmia or hypotension. Moreover, the carbon dioxide insufflation besides the one lung ventilation may cause the hypercapnia. Now, so in this condition, the protective lung ventilation has to be applied, like the tidal volume is given at the 3 to 5 ml per kg of body weight. Respiratory rate keeps to be kept at 50 to 20 per minute. P 5 millimeter respiratory pressure, maximum P max at 30 centimeter of water. A shortened eye ratio should be avoided, which may cause the air trapping in patient with a chronic obstructive pulmonary disease. There are some surgical complications which may arise at the time of operation and will involve the anesthetist. First of all, blood loss. Blood loss is usually low in adult patient and seldom requires the transfusion, but there are some many potential sources of catastrophic bleeding close to the thymus gland. In contrast, the children often requires the transfusion during the thymectomy. Other complications is air embolism. Air embolism is extremely rare in thymic surgery. The air enters the venous circulation through a cut vein, but can only do so if there is a venous pressure is subatmospheric and the walls of the vein are prevented from the collapsing. To prevent this, the surgery can be performed with the patient with slightly head low position, and if the volume of air is large enough, it will cause the airlock in the right ventricular outflow tract, and there will be a fall in blood pressure, and sometimes the arrhythmia and gas exchange will hampered. In postoperative period, respiratory failure is particularly prone to occur within the first 24 hours, and it is this the period with which the anesthetist is more concerned. Patient transferred to the intensive care therapy unit for this close supervision during this period. A small minority of the patients are electively ventilated postoperatively. Majority of the patients are extubated in theatre, having first demonstrated that they are making the adequate respiratory effort, recruitment of the both lungs, and complete recovery of neuromuscular junction of train of 4x4. The particular problem of the early postoperative period are as follows. The effect of the residual anesthetic drug, control of pain, clearance of bronchial secretions, and altered anticholinesterase requirement. Policy is to replace the quantity of the anticholinesterase that has been omitted during the surgery with intramuscular neostigmine according to the formula is 0.5 milligram of neostigmine intramuscularly is equal to 60 milligram of pyridostigmine orally. Regular edrophonium testing of 2 milligram followed by the 8 milligram enables us to determine the frequency of the further doses of the anticholinesterase drug, which are given in as small doses as possible. The oral pyridostigmine should be recommended within a few hours of the surgery. One of the greatest dangers of this period is overtreatment of the myasthenia with this anticholinesterase treatment, which causes the increase in bronchial and salivary secretions, eventually a cholinergic crisis. The interpretation of the edrophonium test may be straightforward. Regular chest physiotherapy is likely to help in the clearance of these secretions. After 24 to 48 hours, the patient can usually be transferred to the general ward and may well move out of the anesthetist sphere of influence. A few unfortunate patients will require the prolonged ventilatory supports in the ICU, and tracheostomy is reserved for who make the slow recovery. Once again, the combined management of the surgical and medical teams is required to ensure that the satisfactory outcome from the thymectomy may be achieved. In general, the patient presenting for the robotic assisted thymectomy, even in the presence of the myasthenia gravis, can be safely anesthetized without the need of prolonged mechanical ventilation or ICU stay. It is possible to avoid or reduce the repetition of those of the neuromuscular blocking agent, and it could be carefully monitored when used. The addition of the regional anesthesia seems to play an important role in this manner, and the main anesthetic skill required for this type of the surgery are similar to open thoracotomy surgery. However, the anesthetic should have experience in the thoracic anesthesia, one lung techniques and one lung ventilation, and the management of the lateral related hemodynamics and pulmonary changes during the procedure to avoid the complications. Thank you.